In this video, we're going to review the changes to evaluation of frontline clinical preceptors as we transition to competency-based medical education. So, the preceptor evaluation, which we've had for about 10 years, is changing, and one of the key principles that's guiding this change is that we wanted to explicitly evaluate behaviors required to enable the best in our residents. And this is not just in a competency-based environment, even in the time-based environment. All of these principles held true, but they just become more important and transparent as we transition to competency-based medical education. The revised version has been reviewed by the Medical Education Executive, the steering committee made up of the divisional directors, and the subspecialty program directors working group. Despite appropriate stakeholder engagement, the purpose of this video is to allow this information to be accessible to our frontline preceptors across the city. So this is the revised form. The first question is about a discussion between the resident and the preceptor. And historically, our preceptors have been pretty good about discussing the responsibilities they expect of our residents, but not all have necessarily engaged the resident to ask them their objectives for the rotation. Now, with competency-based medical education, each resident has their own learning plan that they need to fulfill, and some residents will have already captured certain EPAs, whereas others are still working on those. And hence why it's important for the preceptor to have that discussion at the beginning of their time with the resident to find out what they want to get out of that learning activity. The next two scales about creating a climate conducive to learning and being available to provide support as needed should not be surprising, and we should be continuing to doing a good job about this. What is important is that the being available to provide support and supervision does need to be tailored to the learner's level. So, leaving an R1 to round on 30 patients all day while the staff is in clinic, that's clearly inappropriate. But if you have a very senior resident who's trying to run the team, you have a staff that's micromanaging things, that's also inappropriate to that resident's level. The next three scales are really getting at the crux of the important aspect of why we're moving to competency-based medical education in terms of, did we actually observe the learners do certain skills, and are we giving them that honest, positive, and constructive feedback? Now, for the directly observing my clinical skills, I would anticipate that probably the majority of the residents will score their preceptors in that sometimes to often range. It's probably going to be hard to get to the very often, but I really hope we don't see many nevers or rarelys. And then we should be highlighting and encouraging the positive behaviors our residents are doing, but honestly alerting them to areas they should change and enabling them to improve by giving them tips on how to do that. Next, did we meet with the resident at the end of their time together? And yes, we're all busy, but it's very important to go over how did our time together go, be it a week, be it a month. And the expectation, as you can see from the far right, is that we meet with the resident at the end or within a week of the time together. And with that, the 145 ITERs should be submitted at the same time. And I'd strongly encourage people to just pull up the ITERs and do them with the resident, because we have worked hard to shorten those ITERs to get away from the rater fatigue that has been associated with the previous version. And finally, we do have an overall was an excellent teacher. And the reason we decided to keep this, because often this can still capture elements that each rating scale above misses. So that's the new form. Finally, we're going to end with a demonstration of an approach that residents can take and how staff can engage with the residents that can make direct observation and feedback to the residents as effective and time efficient as possible. The last video in this series was produced by Greg Kohler, one of our R1 internal medicine residents, with Jesse Stach as the resident. But I just want to give you a summary of the key principles from the video. First, the residents need to own the assessment. It's up to the resident to plan which EPA they want to target. And sometimes things can come up organically that you might go, oh, actually, this might be better to get this EPA today. But then they need to ask the preceptor at the start of their time together to make sure that they have permission and not just spring it on the attending. And then get it done. Actually get observed, do the case reviews, and the resident can actually fill in the form and just show it to the preceptor before it's submitted. And then the preceptor is to review and observe what's actually happening. And doing the case reviews, we're really good at actually getting there and observing even just a short 5-minute snippet. We've got to get it done so we know we trust our residents. And importantly, the preceptor has to give honest coaching feedback to help the resident improve.